Hello everyone, today we will be seeing about vestibular neuritis and difference between vestibular neuritis and cerebellar stroke. So first of all, what is vestibular neuritis? Neuritis, itis, it means inflammation, and it is an acute inflammation of the vestibular nerve. So because of this acute inflammation, there is vertigo is present, and this vertigo is very different from BPPV, in which BPPV there was vertigo which was very severe, which lasts for only few seconds, but here there is neuritis of the vestibular nerve itself. So it is very severe and it is continuous vertigo which can occur for 3 to 7 days, and it's an acute presentation. So for this there is no other presentation other than vertigo. Now for diagnosis of this, we do the HINTS test. Now what is HINTS test? That is HINTS. So HI, it is for head impulse test, N it is for nystagmus, and TS it is for test of skew. Now we will see the difference between vestibular neuritis and cerebellar stroke, and we will diagnose this based on this HINTS test. Now first of all, nystagmus. So what is the type of nystagmus in peripheral neuritis? It is of the peripheral type, and in central cerebellar stroke it is of the central type. Okay, then there is the direction of nystagmus. So in vestibular neuritis, the direction it is fixed, that is it is towards the active sides. Now what is an active side? It is the normal side. For example, if right side is my normal side, then the direction of nystagmus it will be fixed towards the active side. While in the cerebellar stroke, the direction changes. It is not towards a fixed or active side or normal side. For example, if this is your affected side, then the direction changes in both the sides. Then optic fixation. What is optic fixation? For example, if you ask the patient to fix their gaze at a particular point, for example this pen, then the nystagmus disappears in case of vestibular neuritis, and it doesn't disappear in case of cerebellar stroke. So we have seen three points in nystagmus, that is direction, type, and optic fixation. Then comes the head thrust. Now what is head thrust? Head thrust, first of all, it is defective in vestibular neuritis, that is known as defective head thrust is known as saccades. Now what are saccades? For example, if I am the patient and the examiner, there are continuous movements. For example, if there is sudden movement in this side, and you ask the patient to look at a particular point in the nose of the examiner or in the eyes of the examiner, then in cerebellar stroke it is normal, that is person is able to fix their eyes towards the examiner. For example, if there is still a stroke, then still the patient can fix their gaze at the examiner, that is known as normal head thrust. But if it is defective, is known as saccades. Now what happens in saccades is person is not able to fix their eyes, and whenever there is a head thrust, then the eyeballs it moves with the direction of the head. These are very sudden movements, and then the person again retries to look at the examiner's eye. So this is what is known as saccades. So saccades, it means the eyes moves along with the head, and then person again tries to maintain the gaze at the examiner's eyes or nose, whatever point you choose. So this is known as head thrust, and head thrust it is defective in vestibular neuritis, that is saccades. Now comes the skew. Now what is skew? Skew is for example, if you ask the patient to look at a particular direction and you occlude one eye. Now normally what happens that we can see with our other eye also, but in cases of vestibular neuritis there is an diagonal movement of the non-occluded eye, either in the upwards direction or it can occur in the downwards direction. For example, if there is a patient of vestibular neuritis, if you ask the patient to look at one direction and then you occlude one eye, then there is direction of this eyeball, this eye, into diagonally. Diagonally it can be either upwards or it can be either downwards. So this is absent in vestibular neuritis and it is present in cerebellar stroke. Now one point to note is, in the patient of cerebellar stroke, the very first and initial presentation is vertigo. There is no other presentation. So if you diagnose this if this nystagmus, it is either because of vestibular neuritis or it is because of cerebellar stroke, then it is a very golden period, and you can give treatment to this patient to prevent the cerebellar stroke. But if you don't recognize the difference now, then it will progress. The cerebellar stroke will progress and its prognosis will become worse with time. So we have seen three differences, that is nystagmus, head thrust, skew. Now these are the hints test. 3 points are done. Now we will also see the history and examination of the patient, in which we will see the cranial nerve involvement, then if there is an dysarthria is present or not, or ataxia. These three things we will be seeing, and all these three things, they are absent in vestibular neuritis and they can be present in cerebellar stroke. Mostly they are present if it's not an initial presentation. So this was the difference between vestibular neuritis and cerebellar stroke. Now there is a law that is known as Alexander law. Now what does it say? That the intensity of the nystagmus, it increases when the patient looks in the direction of fast component. For example, if for suppose right side is affected side and there is a direction of the fast component. So whenever we ask the patient to look at the right side, then the intensity of the nystagmus increases. It is more fast because it is towards the fast component. And if we ask patient to look towards the left side, then the intensity of nystagmus decreases. So this Alexander's law, it is seen in vestibular neuritis. It can be seen. It is absent in cerebellar stroke.